Okay, so let's launch this panel with a question that I think will give each panelist an opportunity to summarize their views about the main topic of this symposium. So I'm going to ask each of you to say something about how we would define a learning health system, and what are the essential components that must be in place for it to function. Because clearly not all health systems around the world have these components. And we are talking here about the VA, that has been doing this for 100 years, as Mike said. So why some health systems are doing research that can help them become a learning health system, and why some health systems are doing, what are the components that do here? So maybe we can start with Kelly.
Sure. All right, hopefully you could hear me. Well, first of all, thanks for the invitation. It's great. I have to say, one of the main key factors is really having this connectedness, connected community, and an infrastructure that we can do this together. And I think to Rachel's point, there are great minds, great work, great research, great clinical expertise and implementations. But if they're all siloed, it's not going to work. And one of the things that we have learned, at least the reason why we built CIPHER, really is to break the silo for at least one component of this learning health system, which is in terms of the EHR data, observational study data, where we have seen so many projects that they're reinventing the wheel every time. If you think about the VA cohort, it's a 24+ million population cohort, and every study uses the same base population, and yet they do the same work every time. Every project, thousands of projects are doing the same data pool. They learn the same things or similar, and then the study closes, and the next new project has to do exactly the same process to get to a point where they can analyze and do the data analytics. So to break the silo, we've thought about, okay, well, how do we capture this information? First, we need to have the understanding within the community, and the Million Veteran Program really provided this platform where we have hundreds of projects under our same umbrella, and we're able to share that information. And building this infrastructure really helped us to see what it can be, and it became a national program under Rachel's leadership, and now we're public facing. We're working with other partners, external partners from the VA, and encouraging other healthcare systems to think about how we can break this silo and learn from each other. Because that learning process, the feedback loop, is also very, very important. It's one thing to build something and have funding to do that through a cycle period, but if it's not improving and evolving, it just becomes yet another project. And we really don't think the learning healthcare system, it's by design, it has to continuously run. In order for us to be able to do that, so having that universal platform of some kind, it will be a very important. And I'll stop there because I think there will be a lot of other ideas that's going to be discussed.
Thank you. I really liked that answer. For me, a learning health system, in terms of how I think about it, like we saw through the presentations, this is going to be a system where we have care delivery that's integrated with knowledge or evidence generation and application, all with this goal, like Kelly was saying, of continuous improvement within the system. In terms of essential components, we heard about some of these in the initial framing talk. I think high quality data is a must-have. Same with a strong data infrastructure. So we need some kind of electronic systems that are capturing data from potentially diverse sources and integrating them, maybe standardizing them in pieces. So that's the data piece. We need analytic capabilities. So we need to somehow use that data to transform it into evidence. And so that's where something like the VA causal methods core comes in as that causal inference engine So we have data, we have analytics, and then we need the implementation procedures to take that evidence and then translate it into some form of impact, whether it's changing clinical care, changing guidelines or policy, as we heard in Rachel's talk. And so through those, I mean, I do want to highlight some human elements that are must-have. So we need expertise. We need trained personnel in the data, in the real-world data, because we need to know where to find features of interest. We need to know how they're recorded, for whom they're recorded, when they're recorded, and so forth. So we need experts in the data. We need experts in using the data for causal inference. And we also need experts in implementation science as well as part of this system. And then stakeholder engagement is something else that we need, I think, through different aspects of the learning cycle. So researchers, clinicians, patients in cases, and so on.
Great, well, I love hearing all of these different responses. It's really getting me going. But in the end, I think a learning healthcare system is about solving a problem. So if you have to clearly define the problem you're going to solve, and what I've learned by working with Nate and all the subject matter experts there is getting that problem selection right is essential. You can't just talk to like one urologist and think you're going to have the question. Oh, I talked to the smartest urologist in the world. You get 6 or 7 of them together to debate the problem for several months and negotiate then with the end user, namely the guidelines, people to say, if we do this study, will you consider it for your guidelines? So you have to think always, what problem are you trying to solve? Who needs to be on board for you to solve it? And you need to bring them in from the very beginning.
I also loved hearing about all these different components and really articulating the many facets that go into a learning health system. I'll say that I think this is really the evolution of a health system, a modern contemporary health system, in that we can't just deliver in a static way the best available medicine. We really help to figure out how can we continue to do better. Having a health system that is designed to actually do that through causal inference research is a tremendous thing, and we see that example in the VA-CAUSAL partnership. In addition to all those things, rather than reiterating them, I just wanted to say that I think the data management part is just so critical, and what Hannah summarized in just a few minutes was just such an enormous amount of work that I know she put into that, that I just wanted to highlight that part, because that's, and every piece is important, but that's one that I think just deserves that additional mention.
Well, I agree with all of that. But what I will say that if we're thinking about how data is used in our industry, and we compare it to how data is being used in other industries, I mean, there's a learning banking system and a learning retail system, and they teach each other things, and we're pretty unsophisticated about that. What Amazon does is they take all their feedback and then they phenotype you for me, when I buy parts for my riding lawnmower, I get phenotyped as the kind of guy that likes power tools, and then they sell me, and then it learns, because it gets feedback when I click on that power tool that they flashed in front of me. So that's a learning system. The banking system, we were all skeptical of them in the beginning. They liked handing our money to a real teller, and it worked. And they've built these kind of engines that get feedback. And I think what we need to do is, in addition to building the research engine, building the evidence generation, we need to know who our customers are, who's going to use the data, how are they going to trust what we give them is useful to them. We just can't feed them things in the abstract. So this involves, a lot of that kind of crosstalk that Rachel was talking about in developing a trusting relationship. I think for the guy, I can't go to, I'm a cardiologist, and I can't go to my cardiology community and suggest something that is against the guidelines necessarily. So, and then I think for the guidelines, you know, if you think about how trials were decades ago, it was the Wild West. You know, and a company could vary a finding, a company could publish selectively, and then we put standards. And we said, okay, if it's a good trial, there's a standard. Now, just one quick story. I was chairing a session where George J.B. Smith and Miguel were giving presentations at the charge meeting, and then we had a vacancy. And it's because someone couldn't get on to do a remote talk. So I pulled them both up and they did a point counterpoint on MR versus causal inference modeling. The main thing they agreed upon was that there's good MR and bad MR, and there's good causal inference modeling and bad causal inference modeling, and sometimes the journals don't know the difference, so the guideline makers don't know the difference. So I think if we're going to get this methodology, like any other, accepted by the guideline makers, we have to create within ourselves. We have to create some standards on what's a good study and what's a bad study, because you can bet that the guideline guys won't know the difference. And then if we develop these standards, and then I think that our clinicians within our organization will be more trusting and accepting of the things that we suggest about our own data. And that should be like the retail example that I started with. That should be an iterative process. When we push something out to the clinic and nobody uses it, or we get negative feedback, we ought to go back and see, did we really goofed here? We didn't give them something they needed to help make the decision.
Thank you to all of you. So you've been describing some of the components of the health system and some of the challenges there. You also, several of you have mentioned data. So in terms of data that healthcare systems have, they generate now, if there were one thing that you could change about data, what would you change? What is either what type of data or how the data are generated, or whether data are generated just for clinical purposes, or there is an interface which the people conducting the research also have an input on how the data are generated? What would you change about how data are collected in health systems? The future was the learning health system. Maybe we're going to start with you.
So I will say that, you know, I don't think we're going to be able to standardize it. You know, the data is collected in these one systems for very different purposes. For instance, some of the commercial vendors collect the data on a billing, what was originally a home-based billing platform. It's a very different purpose than our structure. But one thing that I think I would like to see changed is, as we set up the Phenomics core, which Rachel's predecessor wasn't sure we needed, but Rachel thought for sure we needed it. And then it grew into CIPHER. We have to wrestle with about a gazillion fiefdoms of data. And it's just, it takes so much of our energy. So if we could, you know, centrally locate the data and have some rational, there's good reasons sometimes when certain elements of data are protected in certain ways. But that process has got to be simplified. The way for us to access the literally hundreds of different data domains that exist in our own one system. And the cumbersomeness, not to mention the data that we bring in CMS data, we bring in DOT data, we bring in NDI data, we bring in geospatial data. And that wrangling has got to be easier.
In terms of the data, there are two things I'll say that are critical are follow-up data. That's one thing that we really has shined in our collaboration with the Veterans Affairs, at least I know in my own work, and linking with outside systems to augment that follow-up. So, for example, just a very straightforward example, the National Death Index, I think has been just critical. And then in terms of the other data components, I just always think back to wanting to know the data generating mechanism and really what clinicians are thinking about to make the decisions that they make, and making sure that we have access to those data pieces. And typically, those are things like laboratory values, vital signs, diagnoses and imaging studies, and so having access to those and all of those data points to create a longitudinal picture of what the clinicians were thinking about, that's what would be a priority.
Yeah, so in addition to what you've heard already, I'm always thinking about how can the process of research itself improve clinical care. And so something I find fascinating is that a researcher will spend so much time curating his or her data that they might know more than the clinician does maybe about the patient. You know, you will have said, yes, this person, you know, has Alzheimer's disease. Yes, this person has specifically Lewy body dementia or something. And the clinicians won't know that. And once it's crossed over that rainbow bridge into research, there's no crossing back. So, you know, what I've been advocating for before I left VA and now at Kaiser is, could researchers help work with clinicians and the quality improvement teams on the clinical side to curate the data there and have it secondarily used for research so that both parties could benefit from well-curated data?
Yeah, so I think this is a really interesting question about data collection, what data we have access to. I'm thinking about a clinical setting and how it may add to a burden on a clinician to themselves capture more data that's outside of the scope of routine clinical care. That said, in the future, you know, with emerging technologies, we could see more continuous monitoring of things like physiological measurements, behavioral measurements. These could be through things like wearable devices. There's new technologies for monitoring medical devices remotely, things like that. Some people are working on clinical intelligence tools that are actually attempting to capture workflow and even conversations in clinical settings with the idea of minimizing the burden of clinician documentation. So there could be interesting changes in terms of what data we get and how we get it. But I think all of that said, a first priority is using what we have. So through our work, we're mostly using the structured data. I think that's the tip of the iceberg when it comes to the information that's available in these databases. So we have all of this unstructured data available in clinical notes and elsewhere. And so I think a really exciting frontier is, you know, on the front of AI, large language models, and so forth, to tap into those data resources and make the integration of the unstructured data more routine in some of our studies.
I'll just add a couple of points in addition to everything that's been said. I was going to say, well, we need more documentation of how, why, and when, all those details. But I think, in fact, we need all information about that data point from the beginning of the conception of the design, or whether it's a survey, whether it's you know, other form of collection. There's really lack of information on that front. And you know, once you are trying to integrate different sources of data, we run into this issue of, well, we only have this much information, and we don't have confidence of this amount, the amount of data that we have, but we don't know how to put it because we don't have the information behind these numbers. That's one point I would love to make sure, because it's been done, it's been designed, and I think if we as data users and data collectors or researchers and clinicians spend that extra time to just make sure to capture all that information, I think that will enhance the usability of this information that's been collected. The second point I would say is, it will be amazing to capture how people are using the data and why. And why did someone make that decision? The decision points and justifications of why. That information is very valuable because it brings insights and it really expedites what another person has to think about. And you know, it sort of captures some of the things others have mentioned, but that just getting into the mind of the data user and the team's discussions and documenting that level of why people made that decision point, it will be amazing.
Yeah, let me give you an example, a concrete example of our work. We were curating Alzheimer's disease, along with other dementias, and the metadata about the kind of clinician that was assigning the code was really valuable information, and most data systems don't have that. We happen to have it in VA. We can say, well, this was a geriatrician, a neurologist, a primary care doctor, a dumb cardiologist, you know. And the interesting thing was that if a geriatrician or a neurologist had ascribed a code of Alzheimer's, the specificity was much higher than if primary care did it. We see in our workflows, in Alzheimer's is just generic dementia to some people, and it happens to be in the A's, and if you're scrolling down, you'll click on possible Alzheimer's or rule out Alzheimer's, but having that metadata really changed the algorithm. It allowed us for that specificity. That's just an example of what Kelly was talking about.
Great, thank you. So we're going to open the floor now for people here who want to ask questions. If you have a question for one of the panelists in particular, just please direct the question to a person. If it's a question for the entire panel, that's it. So, and of course, anyone can jump. Friends.
Thank you, Miguel. Thanks to all the panelists. I appreciate all the talks that we're doing this morning. Great stuff. And just want to say that this is such important work that you're doing. VA is the perfect vehicle for this. I am a VA researcher and clinician with our folks here with me today. Just a question, you're talking about data quality and related issues. And so you liked your comment just about, you know, having different clinicians rendering different diagnoses. I'm wondering, for the various studies that are done, how did you then decide which diagnoses to choose for the work that's being done? Do you take it from the problem list? Do you take it from the counted data? Which clinicians are, you know, as a psychologist, I could put in, you know, if I'm seeing a patient, I could put in the diagnosis into the problem list if I so wanted to, whether or not it's accurate or not. And so I'm wondering about that and how that then impacts the results of your work.
Yeah, well, I'll start, and then many others on this can you know, embellish for sure. And I think the first rule of thumb when you're trying to define a disease, an event, is number one, you have to be skeptical. The data is enormously messy. But as I was mentioning, what we've learned from other fields of data, whether it be, you know, retail or banking or whatever, you can get valuable knowledge out of this very, very messy data. There's no one right answer. But the key is to try to define, perhaps with a clinician's help, what is the entity that you're trying to define? Is it an event? And then you don't trust a single approach or a single code. And we have developed rather sophisticated way of working with others in this building, Tanji Kai and Kat Liao across the quad at the Brigham, in developing complex models to get to the right answer. And those models began with very crude hand building, old traditional ways, moved to semi-automated, moved to neural networks, large language models, you know, neural networks, and I personally think that the ultimate key is some form of validation, so that you have a comfort level. The last thing I mentioned, that what we introduced very early on in this process, is that we didn't want to be the arbiter necessarily. So some of these models will allow us to generate not a yes/no answer, but a probability of caseness. And what that has, I think that has enormous utility, a probability of caseness and a probability of non-caseness. I think that usually, as we sit across the table from a clinician, they says, I want definite cases of Alzheimer's disease. And you say, okay, well, I can give you 500 definite cases, but if you'll take a 99% probability, I can give you 10,000. Now, you can choose if you want. If we give them the probability, because in all these cases, now when I'm sitting in front of a patient, I have to decide, does he have prostate cancer or not, so I can give him this toxic chemotherapy that might save his life. But I don't, as a researcher, I don't have all the information in making that. The data density is sparse in some patients' cases. There's leakage and all those kinds of things. So these algorithms, as we build, can generate this level of certainty and uncertainty, and then the investigator can model it. But I completely agree with the premise that you have to take some level of skepticism, and you have to understand how certain you want to be, and to what length are you going to go to generate the validity for your answer. And sometimes it's 2 codes meshed into ever, sometimes it's a highly specific single code, sometimes it's a complex algorithm. The last thing I'll say about this is that we've been doing bake-offs between, say, prediction of certain elements, prediction of a disease or probability. The interesting thing is that artificial intelligence of generating, say, a risk score of a future event, future disease, they perform maybe a little bit better, but that's not the big advantage. So if in that example that I gave when I was talking, we can generate a cardiovascular risk score by pulling out your cholesterol and your blood pressure, but they have to be contemporaneous. And I can only generate that on about half the population. But a 400 variable A can generate something that's pretty close to that on everybody. So the value of some of these the models has to be also weighed against each other.
Can I just add one thing? All this modeling that Mike mentioned, it's what we call the high throughput. It's an amazing tool that we rely on because we have a big system, large data. But underlying all that, we would have to create some labels, meaning we need to actually know the source of truth. And this is very time consuming, what we call the validation. And if we have all the time and resources in the world, that's what we will do, right? We go through the charts and then ask smart clinicians or other adjudicators, like, is this truly ICD code, truly meaning what it's coded for? To make sure that clinicians are marking as they're trying to triage the diagnosed, right? And we want to understand exactly what the disease we're talking about. Now, we build, whether it's gold standard labels or silver standard or bronze, whatever level, we will need some level of a source of truth. But the point I wanted to make was, it's all feasible because we have a large learning health system at the VA, especially. We have one single payer system where we can look at 20 years plus retrospectively and of longitudinal data, where we could see, if you look at all the data, you can see what is the diagnosis, the true diagnosis that we want to use, and what code is really has that level of confidence that can be used for research. So I wanted to make sure that I think one of the talks and one of the questions during the talks, Kate talked about the phenotyping resources, and these are all, again, part of the learning system that we want to learn from how people are doing this, and what's the best way, what's the most efficient way, and we should be applying that, right? And being able to do this at a scale is really one of the struggles and problems that Mike and I and others are trying to solve.
You've been talking about data, how messy data are, and I started to mention AI tools. So I like to think of causal inference in 3. Any causal inference probably has 3 steps. The first step is someone has to come up with a good question, the causal question, and that can be translated into the protocol of evaluation. The last step is someone has to analyze the data to get the final effect estimates, and that part can be automated. If it is not now, it will be at some point. If there is anyone in the audience who plans to make a living out of analyzing data that are ready for analysis, it's not going to work. It's a matter of time that humans are not going to say. But then there's this second part, this part in between that you are talking about, which is how will we map our causal question into the data that we have to make a data set that is ready for the analysis. And this is part informatics, is part statistics, is part. So this is the part where it sounds when you were saying that AI can help the most now, because as Hannah was saying, it's 75–80% of the time that we have in the causal inference. So if you could design an AI tool that helps with this part, what would that tool do? How would it work?
Yes, we have been collaborating with, and we've been learning from scientists to tackle other problems like climate change and doing nuclear physics or astrophysics in silico. And I will say that I think this is the most exciting time to be a population scientist. I remember when I did my own coding for my first abstract in a physician's health study in 1988. From then till now, this is the most exciting time because it does involve a lot more people at the table, the informaticists and the mathematicians, the AI engineers. And I think we've got a lot of those players at the table. I don't know what an automated engine is going to look like, but I think you're right. I think we're going to be able to use some form of GPT to tell it to define a problem and try to analyze it. But it's going to involve a lot of people sitting at the table, for sure.
I think that, Miguel, you're asking about sort of the data cleaning step, the second step, because
that is one name
yeah.
for it, right? They are definitely not ready for.
Yeah, not analysis ready. Well, and so I think the others at the table will have a greater insight about the general issue, but certainly today, right, there are systems that do that can say, AI that looks at a slide and says, this person has, Gleason 1 prostate cancer or not, and you compare how they do versus people, and so I'm wondering, if there's an approach to a more generalized engine, and I know that you worked with the Department of Energy, for instance, to do more large-scale automated phenotyping in your PWAS sort of study.
I could comment first on that. This is a great question, and I think we have many examples that we can share in terms of trying to come up with a big solution for big problems like this. And we've done, one of the examples is we've done a Joseph Eulas in collaboration of the Department of Energy and their supercomputers, which we cannot have done. It took many years, but we've learned a lot, and that's just one small example. But a lot of that, I have to say, optimization of setting up the data, setting up the infrastructure pipeline. If we had that done, then the actual running of the analytics, as Miguel mentioned, that can be automated, right? So if you ask me, what would be a cool AI tool that I would like is if I ask a question of, okay, well, I want to know, everything and anything about a particular disease, it could be MI or whatever other Alzheimer's or other disease. I would like an AI system to go through all data, not only publicly available, but private data behind the firewall that we cannot bridge without the regulatory approvals, and grab the information that I would need to learn about this one question or this disease, and breaking the silo behind, however, and there's federated learning that's happening now, but beyond that, something that could really grasp the entirety of the information that's out there already, and tell me what I need to know about this one particular disease. I think that would be really cool. And then you have the data components you need, and you just have to, like you said, press a button and run your, downstream analysis, whether that's genetics or, epidemiological. I think that will be amazing, which we're missing because of many challenges.
This is an important answer too, because many computer scientists and tech companies in the past were kind of naive about this. It's like, well, you give me a lot of data, I give you answers. The problem is that this data needs a lot of pre-processing. And it seems that, from what you're saying, that it would be good for tech companies and others to make sure that this is what matters. This is the part that really matters. It doesn't matter that much other things, like you have a model that you can predict things. We need to phenotype. And we have an AI tool that can do a phenotyping for us. All right.
Yeah, so I really like these answers. Just to build off of these, in terms of AI supporting this data pipeline, which is a term that we use to describe everything that happens from the raw data to a research-ready data set. I agree, that's where I would like to see AI come in first. And as someone who has been kind of in the weeds in the data, in addition to others here, Hannah, Will, Nick, others, I know that the first step as part of the data pipeline assembly is the phenotyping and feature extraction. So some kind of new tool that would tap into, like I mentioned before, both structured and unstructured data. Because right now we might be interested in developing a variable for performance status or cancer progression, but it's not always clear where to look for those clinical notes in the database. So some tool that could streamline those phenotyping efforts, making use of everything that we have in the database. And then once we have the features, mapping them into the analytic data set is the next step. And so what our analytic data sets look like, there are a lot of commonalities across these projects. So there is some room for automation. So these are going to be longitudinal data sets for many people containing many variables. So this could be a semi-automated process. And I say semi-automated because we still need a human, an expert in the loop to say, who are these people? So what are the eligibility criteria? What are these variables? What are the confounders and so forth? But even making this a semi-automated process, I think would significantly cut down on the time needed to complete these projects.
And I would add that we've got a lot of stuff going on in this space. So what AI is good at a few things. One is pattern recognition. So we've got an experiment with the Department of Energy where we took radiologist read of an X-ray and the machine read of an X-ray, and actually the machine did just as well. And so you can pull out features if you train it. You can pull out features in an automated fashion. Another thing that Barbara was alluding to is that this Kaiser engine that actually can say, okay, here's a gold standard thing. It could do one of two things: find variables that are related to this thing that you didn't even think about. I mean, usually the old way we did it is we'd sit down with the clinician and say, what are the risk factors for this disease that you don't have in your model? And now we let the machine tell us that. Then the other thing is to and I don't understand, exactly how you compare one engine to another, but find people like this. We got a gold standard. Find people like this. The next thing that we're experimenting with is tools to visualize relationships. And I think our disease architecture is about a century out of date. It's organ system based, because that's the code hooks that we put diseases on are the circulatory system, the pulmonary system, and then that's how medicine evolves. If you have lung cancer, you go see a lung cancer doctor. Well, it turns out that biology doesn't work that way, and that if you have a KRAS tumor in your lung, it might behave more like a KRAS tumor in the kidney than another unrelated lung cancer. So I think that the machines are going to be very good at helping us categorize it. And what we're trying to do with different structures that understand the underpinnings of disease is to try to create a new map of disease. One way is to create a map of co-occurrence of disease. And if you color code the dots by the traditional organ systems, you find some of them cluster together. And actually, other colors find their way into that network, and that can be useful if you want to study a disease, a related disease cluster.
And I guess that the question is were those excellent pattern recognition tools that work well in self-contained problems. You are giving an image,
yes.
you are giving that. They said, no, I'm giving you this messy set of 100 different data sources, right? And use your expert knowledge to tell me how to do that. And also, this is probably going to be health system is specific. So Kaiser will have to do it for Kaiser,
it will.
VA for VA, and also this. So
yeah, and that gets to that other issue of just the interoperability between. I mean, I think that perhaps the federated approach is perhaps better than a homogenized approach, where you find one least common denominator standard like OMOP, you try to squeeze everything into those common denominators and then pull the data. We need to allow these data sets to come up with this data set's algorithm for coming up with an MI might be very different than this one. And if I homogenize them through, a single language, I might lose the data, and that's what we see.
Right. Okay. Question. Can you speak up a little bit?
Okay. Madenci time doing AI science, especially with that multi-generalization. So I have a question is do you have any tips or tips or what kind of requirements that we need to enhance the safety and the viability of the learning health system, especially when we have to deal with some real-time data or some less structured patient data such as
You hear the question?
Well, I think it's about how to enhance the learning, the sensitivity and specificity of the learning within the learning healthcare system when you have so many data types, including transcripts, patient transcripts, and the like. And I do think that circles back to the question of, I think we keep returning to the issue of this phenotyping and the data pipeline. And I think you're pointing out that we're in fact in this era of AI and connected health. We have so many different new data sources too, being it the Fitbits, the Apple Watches, people's sleeping monitors, and we can hardly manage the beast that is the EHR, and we are adding new data types. So, and I think the question that stems from it is, I remember my late husband always said, Marco Ramoni always talked about, if you want to tell a male dog from a female dog, you don't need a lot of different data points. You need to, he said, you lift the tail, and that's like the one data point you need. So I think in the context of healthcare and, turning to the clinician, is more data always better?
I completely agree that there's key data, there's critical data elements.
The tail.
The tail. or what's under the tail.
True. Not the tail itself. Yeah.
The question is next.
Okay, this is so I'm an AI researcher and I'm also internal medical clinician with a background in public health and health services management. So what we're talking about how a health system that is learning is made up of many interconnected components that resonated with me. But in real life, this is incredibly difficult to implement. I mean, organic basic clinical practices, the research probably would be at the bottom of the list of priorities. And equally in academia, there's the way academia works is very competitive. So that's not mistaken, and publish or perish. So the system itself is not necessarily geared towards making us learn from a very complex system anyway. So in your views, because you're so much, you have so much experience in this field, what would be key barriers to us achieving a learning healthcare system, and what pragmatic steps could we take today to transform the healthcare system? If you had unlimited resources, carte blanche, what would you do today?
Well, me personally, so I didn't have unlimited resources at the VA, but I had more substantial resources than I currently do. To me, you know, it really frustrates me that NIH never was a fan of infrastructure. And I think we saw it in VA, and I know, you know, in Kaiser, so much of the efficiency and the processes do rely upon having infrastructure, whether it be the phenotyping core, or whether it's it be the coordinating center that can offload a lot of the work from the clinician so that they can focus on this teamwork, sharpening the meaningful question, as we've done with Profound. So you know, personally, I think systems that are truly integrated healthcare systems like Kaiser and VA have the greatest incentives to do this, and that also protected clinician time is essential, and something that we struggle with in the system of value-based care. But to me, infrastructure is the key, as unsexy as that is.
But I'll say, I think, like you're saying, infrastructure really promotes that kind of teamwork and collaboration that is at the heart of everything we do. And in the presentation of our work in response to COVID and that very fast timeline couldn't have been possible without all the collaboration and crosstalk. And that's, I think, what infrastructure really gets at and promotes. So I love that.
And I wanted to add a few things to both Arin and Rachel. You know, this you're absolutely right. You know, I think, you know, when you talk to anyone, not only people in this room and online, but they all agree. In principle, this all makes perfect sense. But how do we actually do this in real life, right? And so, oftentimes, you know, in my mind, we need many things, but two key important things are we need top-bottom like push from the leadership who understands the needs for it, whether it's infrastructure, whether it's to test out more models, and then bottom-up approach of doing more use cases where to continuously show this proof of concept. You know, you saw all these use cases projects that we presented, that co-presented. This is why we went after the immediate high priority use cases that we can tackle with the team we have. But it's critical and priority to the funding agencies for us to continuously promote the importance and make the connections from the leadership end to buy in and do it together, bringing that level of the community together at first. And that's usually, you know, one step at a time, but looking at the high mountains is usually how we are approaching. But I really have to say, it really helps if your leadership really is on the same wavelength with you. You know, at least there needs to be some support at the higher up, whether that's a policymaker, or whether that's through guidelines, or whether that's people funding your projects. Again, you know, it's really sad, you know, that we get funding for 3-5 years, and if we don't get that review, your wonderful, once high priority activity, sort of, how do you fund this? And I stress this because folks here understand this. And every time we reach out to our partners to build partnership together and to, you know, work together in collaboration, that it always comes down to that. You know, how do we fund this? how do we bring it together to actually work together? And that, I think it's a struggle, but it has to be spoken up, and we have to continue to fight for it.
Well, I will say that I think it's happened. I mean, I remember when I was a medical student 40 years ago at the West State VA, they came up with this amber screen, and the labs could come up. Wow, they didn't have to wait for someone to come with a paper thing and paste it to it. It's happening. One of the biggest barriers that we have to knock down, and I think I feel like a kid in a candy store working at the VA, because this barrier between research and clinical care is coming down. And we're using the same tools, highly curated data and a clinical dashboard. We're using it in my lipid program. We're feeding the data to the people. It's got to work though, and I would say it's got to be both supported from the top, but it's got to be accepted and be a time saver. And that Amber computer was great. It saved a lot of time. I didn't have to run, as a medical student, I had to run down to get the lab slips. So it's got to work, and it is working. I mean, right now, what I can do with my computer right now, like toggle across the country and pull data out. And we're still doing it in a rather clunky fashion, and there's a lot of things that we would like to have curated and presented to us in better ways. But what's wonderful is that the VA, and I assume Kaiser, are wonderful places to move things back and forth between the research world and the clinical world.
One quick question.
Hello, my name is Gaziano. I'm teaching from the UK. I have more of a broad question for the whole panel. I was wondering, in a learning health system, do you envision a potential role for, in addition to experts, but also patients and communities, not only as beneficiaries of research, but also an active part of the design and the implementation of research?
Well, I'm gonna call on Mike, because I believe that the Million Veteran Program is a perfect example of motivating. You didn't motivate just one person to come and give their blood and answer questionnaires and be available for recontact. You motivated over 1 million of them to participate in the program, and so. I do think that that especially for certain questions and certain populations like veterans, it's absolutely essential to incorporate them. I think that for me, it all comes down to including them in the community around problem definition and selection at the very outset.
Yeah, I completely agree. I think we're very lucky that we have we already have a sense of community in the VA. It's a special community that was genetically wired to serve their country, and now they serve in other ways. There are many. MVP is a great example that they're willing to serve, but it's like to get broader involvement in the healthcare enterprise, it has to be easy.
Mike, is it true that ABP is the largest biobank in the world right now?
It's the largest high quality one. So 23andMe is bigger, but basically it's questionnaire data, right?
But it is
within a healthcare system.
It is only into.
Yeah, that's the key. So it's the largest that I know of connected. The special sauce is that we got genetic data connected to the richest EHR in the world, and we can follow people without them having to be involved in it.
We are approaching the end of our session, and I like to finish with one question for each of you, but I want you to give me a 30-second answer or 1 minute answer. The question is, okay, we'll be talking about our learning healthcare system and all the initiatives that are in place and how to do this and the challenges. But how do we know that something is a learning healthcare system? When do we know that we have got it?
Well, I I asked, that was the question I asked Chuck Friedman, because I was like, oh, blah, blah, everybody says learning health system, you know, what is it? Is there any, you know, is there any system that truly is a learning health system? And he had to admit that, no, it probably wouldn't be the property of potentially an entire healthcare system, but it's these sort of sub-networks that can ultimately be joined together through shared resources like CIPHER. But to me, it's if you are systematically identifying problems and simultaneously pursuing quality improvement in a measurable way and advancing the future of the care of that condition in again, a measurable way. And I think to call your system that way, you have to do it across multiple conditions and have shared resources that are leveraged by multiple communities.
Thank you. And for the rest of you, you can also give us an example of something that you would like to see happen in the healthcare system. So we can get
I can add to that. I think the one component of what you mentioned is that feedback loop and knowing that an intervention is working. That to me really defines that it's a learning healthcare system, to see that improvement over time in an adaptable system that learns from itself. Right?
So, I mean, I think all these things are, you know, an evolution, and you know, I think that we'll know that we've had success when the clinicians, and it's a slow evolution, when the clinicians have that aha moment and say, boy, this really works, this is cool. Or and I remember when I was, you know, buying gas in Ireland, and I put my credit card in, and it didn't say rejected or accepted, it said deferred. It's deferred. My phone went off, and there was a machine that asked me 3 questions. Are you in Ireland? Are you buying gas? Do you want us to keep the card activated? And I said, yes, yes, yes. And, whoa, this worked. You know, it could have just rejected my card and I would have been upset, but it worked. It made me happy. So when the patients see that this system is working to support them, and when the clinicians have those aha moments, which do happen, you know, all the time, that's when we know we're having success. We're making it's not going to be, oh, yesterday we weren't a learning healthcare system and today we are. It's going to be, are we making progress and having those moments? Thank you, Barbra.
Yeah, so I think in terms of assessing whether we have successfully implemented a learning health system, we can consider different metrics like process for one. You could measure time between the question and generating the evidence and having impact. So the speed of that could be considered as it relates to efficiency of the system. And then as another metric, the impact itself, so the outcome. So thinking about clinical impact. For patients, measuring, are their outcomes better? For clinicians, is there better adherence to evidence-based recommendations and so forth? So those are a few metrics. And then for the second question, which is what we would like to see, what I would like to see really is just sustained investment and commitment to some of these things that we've been discussing. So the data, expertise in using it, and also the infrastructure that's really needed to keep building.
I'll second sustainment to investment.
So when do we know we have actually done this? I think we will know when we stop talking about it and things like this, and it becomes our daily just life. It becomes something that's so easy for me to even, oh, this is not working. I see some success, I want to report that, or such an easy way for anybody to give this feedback and receive the feedback. And when we can see the results that the healthcare is actually improving, we're saving lives, and we're doing a better job, and we're saving money. We don't have to worry about budget cut because we're already cutting our budget by doing a better job. But really, when it becomes just automatic. It's the automatic in our daily lives, in our professional lives. I think that's when we can say it's a success. But until then, I think we have to keep talking about this.
Thank you, Miguel. That's a fantastic way to end this. I want to ask you to please join me in thanking our speakers. the end of our symposium. I'm going to finish just by thank you, giving thanks to the audience here and online, our speakers and panelists. Thank you very much for being part of this. There is a reception upstairs now, and we hope to see you there and for those who are here and to continue the conversation. Before I finish, I also want to thank the Kolokotrones family because it is their generosity that makes this symposium possible, and of course to the Harvard T.H and the Department of Epidemiology for their continued support for this symposium. I also want to thank, since we are talking about VA-CAUSAL, to people at the VA that made it possible. Of course, Rachel, because VA-CAUSAL is her friend, and also Grant Juan, who is the acting chief research officer at the VA now, who has supported and participated in VA-CAUSAL for its first 5 years. He will join us today, but he's a very important part of it. And finally, I like to thank our wonderful staff from CAUSALab. They are responsible for these things happening as smoothly as they have. So please join me in an applause for Jack McDonald, for Joanna Nicholson, and Laura Icate.
First, we need to thank the CAUSALab and Miguel and Barbra for organizing and hosting this one.
Thank you very much. So,